Hello, students. First of all, you give me feedback that whether you are able to see me or not, or audio is clear or not. Then we'll be starting with the class. Good morning, everyone. First of all, give me feedback on the chat box so that I can see whether it's going well or not. Let me see. Just write down audio and video is clear. Just write it down so that I'll be able to seeing it. Just see my comment. Hi, students. Yes, Palak Mini has written, good morning, sir. First comment I have got. Palak, just tell me whether you are able to hear me or not. Audio and video is clear. That's it. Ajay Patel, Sandeep, voice clear. A few more feedbacks, then we'll be starting with it. Visible and audible, sir. Okay, sir, sab sahi hai. Divyanshi, Varnika, Shravan. Good to see you all. Okay. So this is the first time I am streaming it on YouTube so that it's there whenever you are needy. Whenever you want to see it again, you can watch it again, or you have missed the class due to any reason. Some net issues are there also sometimes with Zoom and free conference call. So I've decided to directly stream it on YouTube. Don't know how will it go or how will you like it or not. So I'm just going into my PowerPoint. uh, Wait a minute, where are we? Yeah, wait a second. So without further ado, let's begin with it. As the name of this topic was suggesting, like my thumbnail was suggesting, a mysterious disease, Kawasaki disease. Why is it mysterious? We'll come to know. First of all, whenever they ask some kind of short question or long question, and they ask so many questions in various objective types of exam, whether it is NEET PPG or PLAB or USMLE, Kawasaki disease is favorite for them because it's easy to make very good objectives out of this topic. So that's why you should know Kawasaki disease. Another thing is that Kawasaki disease is not that rare. And I have seen around 20 cases in my career. What happens that it just misses out by clinicians, particularly pediatricians, because it's a disease of children mainly. So what happens? There is long fever, and most of the time, we pediatricians are suspecting enteric fever, some viral fever, or something else, or some autoimmune disorder. But we don't suspect Kawasaki disease so many times, and I have seen around 20 cases, out of which one case had developed aneurysm. Unfortunately, she was a 3 month old baby of a medicine doctor, and all other 19 were recognized early, so they didn't have any long-term sequelae. But this baby, 3 month old, um, came to me after 15 days of fever, and after that time, usually aneurysm formation started. So Kawasaki disease, first, whenever you're answering a short question or long question, you will start with this kind of text, like it's a mucocutaneous lymph node syndrome of acute self-limiting febrile illness of unknown cause, predominantly less than 5 years of children, or a better way of saying is 6 months to 5 years of children are affected. Most common cause of acquired heart disease in children of developed countries. So I just want to ask you, which is the most common cause of acquired heart disease in India? Tell me. Just write it down. I'll see it later on. No pathognomonic test, diagnostic or clinical. So diagnostic is basically based on history taking and clinical examination. No clear cut investigations there. That's why this disease is so many times missed by pediatricians if they are not keeping high degree of suspicion. I now the treatment of choice is IVIG, which has reduced uh, coronary aneurysm formation from 25% to 4%. So it's almost life saving. And once aneurysms are formed, that is really a bad kind of morbidity, and sometimes death can occur. Kawasaki disease is most common cause of early myocardial infarction, early age myocardial infarction, young or youth myocardial infarction. It's the most common cause. If it's missed, then there is coronary artery aneurysm formation, which may lead to later on rupture or infarction, ischemia. Long-term prognosis or initial and current level of coronary artery involvement. How much involved is the coronary? If it is not, then prognosis is good. If you have recognized it early, you have administered IVIG, then its prognosis is good. Subset has risk of myocardial ischemia from CA thrombosis and stenosis, which I have already said. Now, why is it mysterious? So we should go into the history a little bit. In 1967, one young doctor, probably he was just intern, Tomisaku Kawasaki in Japan, had reported around 50 cases of a strange illness where fever was not responding at all, and there were some rashes, there were irritability of those children, which is disproportionate to the fever or illness. There was some arthritis kind of uh, pain or edema, and red lips or tongue. So he had seen this peculiar clustering of few cases, and then he reported it. And eventually in 1974, 76, 77, and 88, much more work had been done, and more understanding about Kawasaki disease had developed. So why was it mysterious? Why I'm calling it as mysterious? Because till now we don't know the exact etiopathogenesis of Kawasaki disease. And whenever we don't know right etiopathogenesis of any disease, this is good for students. You just need to remember one thing, that is what? Etiology is unknown, etiopathogenesis is unknown. So this is such an easy sentence, and it could be applied in so many diseases. When you are answering question, it's good for students. Just you don't need to remember so many things. You just write exact etiology is not known, though postulated hypotheses are that it's related to some bacterial infections. Some says that some past fungal infections around 1 month back may trigger Kawasaki disease syndrome, or some say some viral infections also. What are those bases about these hypotheses of some infectious origin? Is that Kawasaki disease occurs in clustering sometimes. I have seen the cases in clustering too in Jabalpur, and they it's more in children because they are more prone for getting various kind of infections. So, but this is after all just a hypothesis, not a proven one, but well accepted one till now, is that some kind of infection triggers cytokine responses or autoimmune responses, which can lead to this multi-system involvement disease called as Kawasaki disease. But definitely it's not infectious. Means if a child is having Kawasaki disease, it's not going to spread it to others. So pathophysiology, as I have explained, due to unknown etiology. Okay, अच्छा सा highlight करके लिख दोगे, you can write it down, unknown etiology. And what occurs in pathophysiology? Inflammation of small and medium sized blood vessels. Okay, and dreaded complication is when coronary arteries are involved, because there will be aneurysm formation. Aneurysm formation occurs in around second week of the illness. I'll come to a very important point, that why Kawasaki disease is missed by pediatricians so many times. I'll come to that. One graph I will show. Then pediatricians will come to know, because few pediatricians are also watching this video on YouTube right now. Okay, so now because there is aneurysm formation in few cases, around 25% cases, particularly those who were neglected or couldn't diagnosed, or parents haven't seek medical advice, then what happens? There will be features of heart problems like tachycardia, galled brain, hypercardium, dynamic precordium. Those kind of features can be there, but these are not the essential features of Kawasaki disease. We will come to that. How do we diagnose Kawasaki disease? Next slide. Okay, so these are the signs and symptoms you can see here. Like uh, students, those who can make a little bit of diagrams, it's always helpful to make such a diagram, or you can just make some boxes eyes or lips, or you need not to draw it very like artistic kind of, but um, making some depicting some diagram and showing your knowledge through those diagram help to check copies and you get more marks, because examiners usually are not having uh, good enough time to check those detailed notes which you have written, and sometimes your writing may be poor too. So these are the some psychological basis of scoring good in exams. You should make some diagram whenever there is a possibility or there is a opportunity to make. So you can see here the bilateral non-exudative conjunctivitis. So non-purulent conjunctivitis would be there. How would you see it? There will be no pus, but there will be erythema, redness of eyes. Okay. Fever for 5 days or more than 5 days. This is the most important essential criteria. Whenever a child less than 5 years of child is having more than 5 days fever, our pediatrician should keep high degree of suspicion for Kawasaki disease and should look for other evidences. Most important thing is that Kawasaki disease, all the manifestations won't be there together or simultaneously. Rather, they'll be appearing in chronological order. Means, suppose conjunctivitis is disappeared, or mucositis, that redness of lip or red or strawberry tongue is disappeared, then some other manifestation like discoloration of nails and fingers will appear. And that's why Kawasaki disease is missed, because pediatricians remember the signs and symptoms of Kawasaki disease, but they forget this thing that they won't be seeing all the manifestations together. So they have to ask questions. Okay, some relevant questions, whether the child had redness of lips or redness of tongue. Okay, so cervical lymphadenopathy, that you can examine. Rashes, which is usually non-itchy, maculopapular, reddish rashes would be there. Edema of palm and soles, feet, and there can be some pain. Patient could be having severe irritability, which is unexplained by fever, and eventually they may have coronary artery aneurysm. Many times I have seen clinicians, what they do, they rely on echocardiography to diagnose Kawasaki disease, because I said that there is no definitive investigation. So they send child for color Doppler or echocardiography, and if no aneurysm is detected, they think there is no Kawasaki disease. Remember, if aneurysm is formed, already you have lost the case. We have to diagnose Kawasaki disease before the formation of aneurysm, because aneurysm formation occurs in third week of the illness. Okay, and our whole purpose of diagnosing Kawasaki disease early is to prevent formation of aneurysm. So it may be important to do echocardiography or color Doppler. I'm not denying that, to know whether they are formed or not. But diagnosis of Kawasaki disease will not dependent upon this factor or this investigation, which is called as echocardiography or color Doppler. So manifestations, we will be seeing many more slides so that you are having clear idea. I'm giving you one mnemonic also so that you can remember it. This cartoon is showing that fever more than 102 degree Fahrenheit, and you can see tongue पर क्या रखा हुआ है, strawberry. So strawberry tongue, I'll show it to you. It is very interesting sign. I've seen it. Really, they look like strawberry, and strawberry tongue is such a peculiar sign. If you find it with fever, you just keep high degree of suspicion for Kawasaki disease. You may not find other features, but still you may want to treat it, this case as Kawasaki disease, because overtreating won't cause a problem. But if you have missed Kawasaki disease, that child's life could be affected and the family's life could be affected badly. So conjunctival redness, strawberry tongue, red lips like lipstick लगा लिया हो किसी ने. This kind of red lips could be there. Sometimes few children are having already red lips, like they are fair skin and red lips. So then you may be having difficulty to differentiate. Then you have to ask it to parents that इसके lip जो हैं पहले भी इतनी लाल रहते थे या अभी हैं. So this kind of things. So can you see this strawberry tongue? Okay, red tongue, red and dried lips. Many times both these findings are there together, like red lips and red tongues. But sometimes you may find only red lips, or you may find only red tongue or strawberry tongue. You can see here, this is discoloration of hand and feet skin. It's a late sign. It occurs after third week. So by that time, other signs, other inflammatory signs would be over, and by this time already aneurysm formation would have happened if you have missed it. Now, how do you diagnose Kawasaki disease? So as I said, it's a clinical diagnosis: fever for more than 5 days duration, plus 4 of below criteria. So you should remember that fever is exclusive criteria, that is essential criteria. Okay, and then club with that fever, you could be having these features like oropharyngeal changes. Oropharyngeal changes like redness of lips and redness of tongue, which I've shown it to you. Changes in peripheral extremities like edema of hand and feet, cervical lymphadenopathy, polymorphic non-itchy rashes, then bilateral non-purulent conjunctivitis. So many times they ask various objective questions in NEET and all. So you can see here, first of all, they can ask a question giving a case scenario, and they will be giving you some confusing options like SLE, systemic rheumatic fever, systemic rheumatoid arthritis, sorry, and Kawasaki disease. They may give you this kind of feature like fever for more than 5 days duration with some joint pain and rashes. Uh, there is non-purulent conjunctivitis. What could it be? So I am very much hopeful that after these slides, you would be able to pick it up right answer. Okay, and sometimes they ask which is the most common manifestation of Kawasaki disease. So most common one will be what? Out of this, write it down in chat box. I'll see it. Most common would be oropharyngeal changes, or bilateral non-purulent conjunctivitis, or fever. Answer would be fever. Why? Because fever would be there in all the cases. But if option is not given as fever, then other options would be relevant. Edema of hand and feet, and there would be erythema also. This kind of erythema could be there in dengue fever also, and sometimes edema of feet and hands, and there could be some pain and tenderness in dengue fever also, in chikungunya too. But this is a feature of Kawasaki disease if fever is more than 5 days. Rashes, polymorphic maculopapular rashes, non-itchy rashes, self-limiting rashes. These are discoloration of skin over around nail beds. Usually, this is severe discoloration. Buse line could be there in many other conditions, sometimes normally also, but it occurs in Kawasaki disease also. Remember, though this is not included in diagnostic criteria, that is severe irritability, but it's a very good sign to understand whether this fever is because of Kawasaki disease or not. I have suspected cases because of this unexplained severe irritability of the child. Severe irritability is a good symptom of Kawasaki disease, though that's not included in the diagnostic criteria. Why is it not included? Because it is very non-specific. Irritability could be because of so many other causes too. So that's why it's not included, but it's a very good pointer. One more pointer of Kawasaki disease is if a child's BCG scar is reactivated. Okay, that BCG scar is reactivated, or severe reaction is there around BCG scar. There are many reports which suggest that it's because of Kawasaki disease. You know that after this COVID infection, UK has published a large report when many children are coming with Kawasaki disease, and they are correlating this occurrence with COVID. We'll come to that later on. So all the manifestations together, most common manifestation or the all manifestations, bulbar conjunctivitis, that is non-purulent one, non-exudative. Palmar erythema and edema, polymorphic rashes, strawberry tongue, and lymphadenopathy. And dreaded complication is this is autopsy finding, that is aneurysm. See, the coronary artery aneurysm, ballooning of the coronary arteries. This is the most common acquired cause of heart disease in developed world, and in India, it is the second most common of acquired heart disease. First one is, I hope you might have written it because I'm seeing right now PowerPoint. I'm not seeing chat right now. I'll be seeing chat afterwards, after completion of class. Then I'll be asking few questions and we'll be answering your questions too. So this is ballooning of coronary arteries, and this is the second most common of acquired heart disease. First is acute rheumatic fever or rheumatic heart disease rather. So I don't like mnemonic much. I don't remember things with mnemonic, but many students want to know some mnemonics because they have to mug up so many things, and in pre-PG time it could be handy to remember some mnemonics. Because I find even more difficult to remember mnemonic and then converting it to actual thing. So but it's up to us. Our brain functions a little bit differently. All of us are having our own method of studying. So those who find mnemonic as helpful, for them it's interesting one. Cream is but with fever. First is fever, okay, and then comes cream. So cream is C for conjunctivitis, non-exudative, rash, polymorphic, non-vascular. You can write this kind of mnemonic in your answer sheet also if they ask short form, short question, short mark question. Edema or edema of hands or feet. A, adenopathy, cervical, often unilateral. M, mucosal involvement, erythema or fissures or strawberry tongue. So if pediatrician is listening to me, this is an extremely important differential diagnosis for any prolonged fever. Extremely important, and because it's having long-term sequelae, so we shouldn't miss it out. And the treatment is quite safe relatively. Yes, only one thing is that IVIG is costly, so costly treatment we might have to give, but at least that won't be that won't cause any harm. But if we miss it out, then really that's really harmful. So Kawasaki disease is mucocutaneous lymph node syndrome, is a rare childhood disease that causes inflammation in the walls of small size and medium size arteries. Though it's not that rare, it's rarely reported, rarely diagnosed, because all the manifestations which I have mentioned till now are self-limited one, except coronary artery aneurysm. All other manifestations will be gone. Okay, so nothing will happen to the child immediately. If a doctor has missed it out, child eventually will be all right after 2 to 3 weeks of fever or problems, and then he will look all right, though he may be carrying aneurysm inside, which may manifest later on. It is most often seen in children under the age of 5 of Asian descent. Yes, Asian people are getting more commonly. Chinese race particularly, it is somewhat more common in boys than girls. Ratio of boy and girl is 2:1. Okay. So again, this is the same reminding you cream. Okay. Now, investigation. So just a brief summary till now what we have done. We have, when we are answering a long question, first of all, some little bit introduction, like it's mucocutaneous lymph node syndrome of unknown origin, may cause aneurysm. Is the second most common cause of acquired heart disease in India and first most common in developed. So this kind of introduction you will write. Then a little bit of history. In 1967, Dr. Kawasaki has reported 50 cases, short one line. Okay. Then etiopathogenesis. First line would be easy. That is, write it down. Should be the first line when you're writing etiopathogenesis, and then second line could be it involves small and large vessels. There could be cytokine cascade reactions due to some bacterial or viral or fungal triggers. Then we have discussed signs and symptoms and diagnostic criteria. That is signs and symptoms as well as diagnostic criteria. Clear? Then most important features like irritability, BCG scar, which are not there in diagnostic criteria, and irritability. Now we are coming up to what where have like what now we have to do investigations. Investigations initially you would be excluding all other causes of fever in your area. For example, dengue fever, enteric fever, malaria. Obviously, a child is having fever for more than 5 days. Then first we have to look for common causes. We are not going to jump into as this child is having Kawasaki disease directly without excluding other causes. The child which I have mentioned in my career, that was 3 month old girl child, and she had aneurysm. She was a child of a medicine doctor, and her husband was in PGI Chandigarh. How it was missed? Because by bad luck, this 3 month old baby had falciparum positive too. So doctors suspected obviously falciparum malaria, and then they started treating it as falciparum malaria. When she didn't respond to artesunate, then they thought that it's resistant to artesunate, and they gave quinine, which was quite valid. A child who is having MP positive for falciparum and not responding fever, they tried quinine for initially falcigo, that is artesunate for 5 6 days, then quinine for 5 6 days, and by this way they missed it out, and it was atypical Kawasaki. I'll come to that. What is atypical Kawasaki? When Kawasaki disease is in less than 6 months old child, or all the criteria are not present, then it is called as atypical Kawasaki disease, and it is missed most frequently. So atypical Kawasaki disease, she was less than 6 months old. She was having excoriations, which is a feature of one that is because it is mucocutaneous lymph node syndrome. So she was having perianal excoriation also, but perianal excoriation is so much common in 3 month old child. The pediatricians confuse it with diaper rash because of some loose motion. So she had perianal excoriation, perilingual excoriations a little bit, and some non-purulent conjunctivitis too. But all of those features were not present together simultaneously. She came to me on 18th day of uh, illness, and then we suspected Kawasaki disease, and then turned out to be having aneurysm too. So this happens. So that's why we have to rule out first common illnesses, but while ruling it out, we won't rule out Kawasaki disease too. Simultaneously, we have to keep differential diagnosis in our mind. So complete blood count, ESR would be raised as it is inflammatory condition. ESR could be as high as 100. C-reactive protein would be higher. C-reactive protein could be more than 6 because sometimes it's given in units, sometimes it's given in milligrams. So I'm not giving you that particular pinpoint data. You can, particularly UG students can remember C-reactive protein is raised. Blood culture, so that you can rule out other bacterial infections or some other problems. Then you can go for some autoimmune worker. This culture and of throat swab or stool is not needed. Okay, it's not needed that much. And then renal function test, liver function test, chest X-ray. All these routine relevant investigations are necessary. Important thing among that CBC finding is that this is also asked in pre-PG question. This disease is one of those diseases where too much high platelet could be there. There is thrombocytosis in this disease. And sometimes you confuse Kawasaki disease presentation with what? Dengue fever also. Why? Because there is fever, there is joint pain, there is irritability, there is rashes, edema, all these things could be there in dengue fever too. And thrombocytosis can differentiate it easily with dengue fever. Platelets could be as high as 10 lakhs after first week of illness in Kawasaki disease. So thrombocytosis, whenever you pick it up, that CBC report in such kind of presentation, you first look uh, platelets, whether there is thrombocytopenia, normal or thrombocytosis. If there is thrombocytopenia, it's very unlikely to be Kawasaki disease. Though thrombocytosis can be there in dengue too, but it won't be as much high as 10 lakhs. Then diagnostic investigation for complication is what? Annual formation. So color Doppler and echocardiography, gold echography by pediatric cardiologist is recommended, because I've seen so many times adult cardiologists are not trained to pick up those small aneurysms in early phases. So this also happens. Now, treatment. Treatment, first of all, you will stabilize a child. Whenever you're writing a treatment for any sick child, you write it with airway, breathing, circulation management. Or you ये long question है तो और लंबा करना चाहते हो, if you want to prolong it, how will you write? First admit, then airway, breathing, circulation. Third is supportive management. Supportive management is symptomatic management. For example, child is having fever, pain, psychological support is needed, nutritional need is should be taken care of, IV fluids may be needed. So all this kind of supportive treatment is most commonly, they are common in fortunately for students, common in most of the illness. So supportive care, one point you are always having handy to write down in long question, and so many students miss it out. They directly jump into specific treatment. Then comes specific treatment. So specific treatment is a straight away IVIG, high dose IVIG, and it's life saving. It's usually it's very safe. Rarely it may cause anaphylaxis, so because child is hospitalized, so you'd be taking care of it. You would be having all the treatment available for anaphylaxis in your settings. So it's by and large safe. I haven't seen any reaction till now. So IVIG, 2 days regimen, 4 days regimen is there, or one single dose regimen is also there. Uh, Now, when apart from IVIG, what you do, you have to give aspirin high dose. Aspirin high dose, that is around 50 to 100 milligram per kg per day in 4 divided doses. Okay, so you give this aspirin high dose for 2 to 3 days. This kind of aspirin dose is given in acute rheumatic fever too. So aspirin would be given for 2 to 3 days. This high dose, so that he would be having less inflammation. It won't reduce aneurysm formation. Aneurysm formation is reduced by IVIG only. These kind of questions could be asked in PPG too. And so aspirin would reduce his symptoms like pain, fever, and as well as inflammation, generalized inflammation, which is going on. And the child who was not responding to any kind of fever, for enteric fever, various antibiotics these children have, or antimalarials they have already got, then they were not responding. But as soon as you give IVIG to them, they respond very rapidly. Within 24 hours or 48 hours, they become all right. Their irritability is gone. They started playing. They are not febrile anymore. So this happens after giving IVIG. Okay, and when this has achieved, they are not febrile anymore, then you will continue with the low dose aspirin, 5 milligram per kg per day for 4 to 6 weeks. Why? Because if aneurysm formation occurs, so there won't be any thrombosis formation, at least, because whenever there's ballooning of arteries, there is more possibilities of making thrombus. Those thrombus can cause later on embolies, heart attacks, brain stroke, so many problems they can cause eventually. Now, if there is no response even after giving IVIG, sometimes rarely it happens also. So then you have to repeat IVIG dose again. You see the right side of the lymph, okay? And sometimes if there is primary cardiac involvement is there, then you have to give IVIG more frequently for longer duration of time. And steroids, though having controversial role, but may be tried in those cases where you are not getting any response. The choice is methylprednisolone or prednisolone. Now, if fever is still persisting, then you will consider giving infliximab. Fever is persisting or other signs and symptoms are persisting, patient is not responding, that means you have to, CRP is raised, ESR is raised, then you will consider giving infliximab. Okay, that is monoclonal antibodies, costly one. Now, as I was saying that in England, this journal is published, an inflammatory syndrome in children that resembles Kawasaki disease may be linked to COVID-19. UK pediatricians release a working definition that includes. So I said, though this is not an infectious disease, but it is usually triggered by some infections, particularly those infections which are happening in clustering, like measles, like chickenpox, like some other bacterial infections, like streptococcal epidemic is there. So then after 1 month, you may start finding clustering of Kawasaki disease cases too, like in case of acute rheumatic fever. But it's not exactly autoimmune too. There's some cytokine responses. We don't know the exact etiopathogenesis. What they found persistent fever, exclusion of any other microbial cause. They have excluded organ dysfunction with additional features. And those kids were either positive or sometimes negative too. So this was their observation. So now, as I've completed almost the clinical part, now in which season it occurs more? So you can see this. One of this publication is showing most common one is April to June, or spring. You may say spring or summer. Okay, in that time it occurs more frequently. Non-purulated conjunctivitis. Now, what is incomplete Kawasaki disease? Incomplete Kawasaki disease you may find many times if not fulfilling all the criteria. And criteria was what? Fever for more than 5 days in 6 months to 5-year-old children. So if apart from this definition, something is happens and having some findings or criteria for Kawasaki disease, like I've mentioned, given you example of 3-month-old child, then you would be calling it as incomplete or atypical Kawasaki disease. The treatment approach would be same because complication rate would be same, even more incomplete Kawasaki disease is having more chances of formation of aneurysm, because if child is less than 6 months age, they are having more probability of forming aneurysm, as much as high as 50%. If fever for less than 5 days with two criteria, or a less than 6-month old child with more than 7 days fever without any criteria to, you have to keep high degree of suspicion for Kawasaki disease. Okay, and other corroborative evidences like positive CRP, raised ESR. Sometimes these CRP and ESR, doctors take it as only bacterial illness, but sometimes it could be Kawasaki too. Remember that. Okay, and you don't go up to echo for diagnosing Kawasaki disease. Clear? Now, this one is extremely important and very interesting graph to understand this mysterious disease. And this graph will be extremely helpful for all the pediatricians, for final year students too, but all the practicing pediatricians too. See, this chronological order you have to remember. You can have this printed graph under your table, prescription, like where you can refer it out whenever a prolonged fever child is there, if you are unable to remember it. See, fever is acute manifestation which will start from first day. You in x-axis you are seeing what? This is weeks. 1 week, 2 week, 3 week, 4 week, 5 weeks. Okay, and these are manifestations. So fever start very early from first day, and it will remain there, okay, on initial phases. Sorry, this diagram, okay, yeah, I'll continue with that. So first day to prolong, it may go up to like 7 8 days. I'm not finding it good. I think it should be days, because fever usually lasts for 3 weeks, not more than 3 weeks. After 3 weeks, it starts coming down, even if you don't treat it. Arthritis appears after only first completion of first week. Clear? Cardiovascular involvement, particularly aneurysm formation, occurs after 3 weeks. By that time, fever would start disappearing. Other acute manifestations like lips and conjunctiva or red conjunctiva won't be there. If you're seeing aneurysm, by that time you won't be seeing red lips and red conjunctiva. So if you're finding aneurysm in a child, he has come to you late, then you will ask parents that leading question, that whether they had this child had red lips or strawberry like tongue, or because this is so striking, they are usually able to remember. Cervical lymphadenopathy start from around first week, end of first week, and will last up to 3 weeks. Thrombocytosis start from 5 6 days of illness, and may last for a longer period of time, up to 3 weeks, maybe more. So this was all about Kawasaki disease. Now I am coming to the chat option and I'll see what have you written. Now, have you written few answers or not? Okay. Idiopathic. Shruti Rao has written idiopathic. Very good. Idiopathic. Unknown etiology. Idiopathic. Yeah, most common manifestation of Kawasaki disease if fever is given, then because Tiwari has answered fever. Very good. Fever. But if fever is not there, then what? You should write it down. If there is no fever, then what? Now I will invite few questions. If anybody is having few questions relevant to this topic, then please answer it to me. Sir, one problem with this public platform is a few irrelevant question we get, which is not there in our topic. That could be disturbing to our students, but it's all right. It's up to you. You give me feedback. First, most common cause of acquired heart disease, rheumatic heart disease by streptococci. Angel ने आंसर किया है. Well done. Prabhat Chabra, unknown etiology. So all of you have answered, participated well. Uh, I'm waiting for just few seconds so that you may ask any question related to Kawasaki disease. Just ask me something. I'm asking you, okay, um, on which son Kawasaki disease first 50 cases were reported? Tell me, tell me, so that I will know that you are with me or not right now. On which son and which doctor? Young doctor. Probably he was intern. See how imaginative, constructive he was at the time when he was so young. Mukesh Sanket has written. Yeah, Varnika Agrawal, very good. Very good, Varnika. 1967. 1967. Wonderful. Vaishnavi, 1967. Excellent. Wonderful. So you were attentive, you were with me. Now answer me, are you able to recall everything which I have taught you just now? I'm summarizing it with like just heading point, like introduction, then history, then etopathogenesis, which is the easiest part, then diagnostic criteria plus clinical manifestations. So fever plus how many criteria out of five? How many criteria should be there in typical Kawasaki disease? Fever with how many criteria? Golu Kumar 1967, Suromya Jain 1967, Prabodh 67. Yes, well done. So how many criteria apart from five criteria? Fever plus how many other criteria? Tell me. Waiting. Are you able to hear me? 4 out of 5. Palak Bansal, well done. Excellent. 4 out of 5 criteria. Well done. Which is the most striking feature of Kawasaki disease, which parents usually remember, able to recall if you ask them. And this is so much helpful for a pediatrician to diagnose Kawasaki disease. Sakshi Jain has written 3. It should be 4, Sakshi. Saurabh Singh, Gol, Swastika Ghosh, Ankita Tantuwai, 4. Fever plus 4. Excellent, Mukesh. So, which was the most striking feature which parents usually able to remember that is related to a fruit, a beautiful fruit, most beautiful fruit. Most tasty is I think are mango, but most beautiful I found is what that fruit is strawberry tongue, Vedlan Tantika, Ankita Tantuai, strawberry tongue. Very striking feature. Okay, very striking. Strawberry tongue. Okay. Now, which was the symptom which I have mentioned but was not included in diagnostic criteria because it's non-specific manifestation, but it's a striking feature in Kawasaki disease, a striking symptom, which is disproportionate to something. Palak Bansal has made beautiful this strawberry what is it called? Emoji. Strawberry emoji उसने भेजा है पलक ने. Well done. A new way of learning, isn't it? So my question is the feature which is non-specific and not included in diagnostic criteria, but very much helpful. Well done, excellent. Aru Jain, irritability. Suramya Jain, irritability. Ankita, severe irritability. Zahur SK, irritability. Excellent, excellent. Irritability disproportionate to the fever or his apparent symptoms. Now, aneurysm formation occurs by what time? Aneurysm formation occurs at what time? What time of illness? What days, what week? What days or what week? Aneurysm formation occurs at what time? Well done, Preeti. हर्ष 3 वीक्स. गोलू मुझे थोड़ी सी देर से मिलते हैं एक्चुअली यहाँ पर, इसलिए मैं बार बार बोलता रहता हूँ. एंजल 3 वीक्स, तुम लोग पहले ही लिख चुके होते हो. जबकि निष्ठा, वेल डन. मुकेश रावत, वेल डन. नाउ my question is, a pediatrician has seen a case and he suspected Kawasaki disease on 10th day of illness because of some strawberry tongue and red lips and fever, and he wanted to confirm it by some investigation. He sent child for a good color Doppler to a pediatric cardiologist, and that found to be normal. Now pediatrician has excluded Kawasaki disease and he's treating this child in some other lines. Could it be a blunder or not? Is it a blunder? Yes or no? Is it a blunder? It's a blunder which may occur to anybody. I'm not, because this understanding that, and if no aneurysm, no Kawasaki, this understanding is there. Yes, it's a blunder. Suramya, Sangam and Varnika, Angel. Why it's a blunder? Because he has suspected it so well. Now, just because of one investigation, he has ruled it out, and now after 3 weeks, this child may have formation of aneurysm. And if aneurysms are formed, child has to be on some kind of initially on low molecular heparin and later on anticoagulant for a very longer period of time. Sometimes he may need surgery or stenting, or it's a difficult life. It's a difficult life. He won't be having strenuous activities. So we have to prevent this dreaded complication because it is preventable if we treat Kawasaki disease. Yes, Akash Katara, yes, because of coronary aneurysm, yes. Eventually, because later on it may get formed. How many percentage of Kawasaki disease patients form aneurysm if not treated or not detected early? How many? Yes, waiting, waiting, waiting. Objective question is, I'm giving you option. 1, 25%, 250, 300, 4, none. 25, well done. 25%. But now these kind of tricky questions they ask, like if they have written atypical Kawasaki or incomplete Kawasaki, then this percentage may go higher. If both the options are given 25 and 50, then you may pick up 50 if atypical Kawasaki is asked. If okay, because why? Because atypical Kawasaki disease is picked up late also, because so many times it's missed out. It's missed out. Now, tell me in CBC, which is the most peculiar investigation you will find, and value can be up to what? I want more new names, new faces, new right? Someone new. Like okay, so that I know Soromya, Palak, Aru, Sakshi, Mukesh. So many of you are quite attentive, but few the quiet one, the shy one. I'm having one more option in this live stream. I may bring uh, someone of you on this like video chat. Okay, at least 10 of you I can bring. If you are willing, sometimes we can be appearing on this video chat. You can directly, rather than typing, you can come with me like classroom. Anyway, Shilpi, okay, very good answer. Palak, Preeti, Shilpi, Pranshu, Angel, Zahur, well done. No, Palak has written CRP. Yes, CRP. My question, Palak, was uh, about CBC, complete blood count. Okay, about blood, complete. Your answer is right, but up to I was asking about complete blood count. You have written it later on. Right answer. Okay. Mukesh, well done, well done. So this was the class of Kawasaki disease, and it took around 50 minutes. I am hopeful that you are able to recall everything, because any purpose of any class is that you don't waste time. You are able to recall everything which you have learned through that class. If that after that so much of time, 50 minutes, 40 minutes, 1 hour, you're not able to recall the things, then purpose won't be solved, and it's a failure of teacher too. So if you are able to answer so many questions rightly, that means I'm very much satisfied. But yes, about this new experience of this YouTube, because this video would be kept uploaded over there too, like on my channel. You can watch it later on. If someone has missed, any of your friends have missed it, sleeping or due to any reason, net connection, light, then they can watch it later on too. So just tell me, this way is it good, or we should continue with Zoom or free conference call? One more option we are having, we can do this way on YouTube, and we can keep it unlisted, so only you can, if you are able to watch it, those students who are in final year, not others would be able to watch it, like other college students are there or pediatricians are there. So just give me frank feedback, what do you want, what do you want, and on give me this feedback on WhatsApp group which you have. Okay, any question? I'm waiting for just 5 to 10 seconds. I'll wait. If I'll appreciate if anybody of you may ask something. Okay. Well done, Zahur. Thrombocytosis more than dengue. In fact, dengue might be having thrombocytopenia or normal platelet, and sometimes dengue fever could be having thrombocytosis too also. But thrombocytopenia is feature of dengue hemorrhagic fever. Hmm. So I'm just giving 10 more seconds for any questions. Harsh, thank you. Thank you. Harsh has written, thank you, sir. तो नो क्वेश्चन मीन्स या तो सब कुछ समझ आ गया है या कुछ भी नहीं समझ आया है. सो मैं पहले ऑप्शन को चुनना चाहूंगा कि तुम्हें सब कुछ समझ आ गया है. आई डोंट वांट टू थिंक लाइक दैट. सो गुड स्टूडेंट, so much attentive, intelligent, wise, obedient, disciplined students like mine have not able to understand anything. I don't believe that. So I think all of you have understood everything which these slides or this class were telling you. So bye. Give me feedback. Don't forget to give me feedback on WhatsApp group. It's my request because it's important to take decisions. Okay. हाँ, या जहूर ने कुछ लिखा है, उसका कमेंट तो बनता है. इसको मैं डिस्प्ले पे डालता हूँ. देखो सबको दिखेगा ये वाला. मैं शेयर स्क्रीन को बंद करता हूँ तो फिर दिखेगा. स्टॉप स्क्रीन. यस, जहूर का कमेंट दिख रहा है. So much helpful as we are at home and no classes of final year. Please take more classes of other topics. Though definitely I'll enjoy to take those classes, and sometimes I may take class of some pre-PG topic too. Like if you want to learn some pre-PG related topic, you may suggest it. I may do it on YouTube so that other people can watch it too. Uh, so the whole comment is displayed here. So thank you very much. I'm waiting for your response on WhatsApp. Thank you. Thank you. Bye. Bye. Bye.